welcome to EACS 2024. I'm Alice, I'm here with CTSNet, and for this interview I'm going to be talking to some allied health professionals about their role and about what coming to a conference like this can offer. So I'm here with Catherine and Kat. Can you introduce yourselves and explain your roles?
Yeah, so I am Catherine. I'm an advanced clinical practitioner at QE in Birmingham, but I also do a role for SCTS. I'm in charge of the education side of things for the nurses and allied health professionals for SCTS.
And I'm Kat. I'm a brand new trainee advanced clinical practitioner, so right at the start of everything, and just learning the ropes at the moment.
So you two are advanced clinical practitioners. So what does that role involve, and what are your backgrounds? And also, if you could talk a little bit about other types of allied health professionals as well.
Yeah, so my background is nursing, so we call them advanced clinical practitioners because that's the masters that we do. So we do a masters in advanced clinical practice once we've already established in a role that we're already in. So my background is nursing, so I did a bachelor's degree of nursing, worked straight into cardiothoracics. It was one of my placement years as a student nurse, so I decided cardiothoracics was for me, got a job in Oxford and worked there. Basically, I went to a conference, got really inspired by some people around me, decided I wanted to be a nurse practitioner. Then I applied for a job and moved up to Wolverhampton and became a nurse practitioner up there. You hear different phrases for allied health professionals like nurse practitioner, advanced clinical practitioner, advanced nurse practitioner, what do they all mean kind of thing. So when you do advanced clinical practice, you can be any background prior to doing your masters. So as I say, I did nursing, but you can be a pharmacist, you can be a physiotherapist, you can be a paramedic. So within our team at the QE, we've had a physiotherapist within our team. And we're about to, we've just recruited a paramedic who's about to start with us this month. So that'll be really exciting. It'll be good to see what they bring to the team. Lots of different experiences, different roles, and what they bring back to the team in the world of cardiothoracics, really.
And what was your background before you started your training?
So I had a background in cardiology, cardiothoracic intensive care, and then critical care outreach, but I knew from my student days that eventually I'd like to progress to being an ACP. And I've worked with some fantastic ACPs in lots of different specialties as well, so cardiology, orthopedics, stroke, things like that, and just always inspired by the level of knowledge that they bring.
Yeah, I think it's really interesting about how you can come from different backgrounds, because obviously you bring different skills, you bring different knowledge, different outlooks, and it's just, so important for that collaborative working. But obviously, once you're in that role, day to day, you are based on a cardiac surgery ward in your role as what specifically you two do, which might be different for other people in different places.
Absolutely.
We have our surgical care practitioners, and we have, other people in different departments, and thoracic surgery, their roles are slightly different. But if you could just talk us through sort of day to day what your roles are on the cardiac surgery ward.
Yeah, so as you say, the role differs depending on where you work. It's a bridge. It's a bridge role that basically was introduced to counter the changing junior doctors, the schedules, and to be able to help with the work time, the working hours that you were allowed to work, and to bridge that gap. So it's an advanced role. So you're doing a lot of the roles that you would normally expect your junior doctors to be doing on the ward. So our typical day would be coming into work, we run through all the patients, separate them up between the team so that we all have a group of patients to look after, essentially. And then we help with we do the ward rounds, lead on the ward rounds with the registrar, and sometimes the junior doctors as well. We then do any of the roles that are needed from the ward round. So that could be organising tests, requesting imaging, reviewing different imaging, looking at bloods, taking bloods, reviewing all that kind of stuff.
Referrals to other MDTs, discussions around
utilising the wide
care.
MDT, yeah. Particularly working very closely with our physiotherapists. So especially in cardiothoracic surgery, like the role of a physiotherapist is paramount, especially in thoracic surgery. Like there's so many so many things that they can do to help our patients progress that as nurses and in nursing background that we might not necessarily have thought of or be confident or competent to do. But it's also been that bridge between our surgical colleagues, between our dietitians, between our the whole MDT. We also clerk all our patients in. We discharge all our patients. We do all the prescribing for all our patients.
Actively involved in the list planning, the MDTs, aortic MDTs as well. So just like you say, bridging that gap between all of the services, really.
Yeah, and I think what's really key for our allied health professionals within cardiothoracic surgery, and I'm sure it's similar within any kind of specialty, but these are advanced roles where people have worked within the service for many years. So you very rarely get an ACP or an advanced physiotherapist or a surgical care practitioner within cardiothoracics who hasn't done it for years, hasn't done it for many, many years, taken lots of exams, done lots of courses, and essentially they have a love for the specialty. Like that love for the specialty is there. And through being in those positions for long periods of time, you can then be that person to help progress with the junior doctors as they then rotate through. So a real benefit is that we can confidently take care of the patients pre-op and post-op, and it allows our junior doctors to be able to do the things that they need to do to be able to progress within their careers. So going to theatre, going to clinic, doing the hours that they need to do, creating their research, and also working with the junior doctors to be able to do things like research projects, case-based discussions, all that kind of stuff. Because we have a lot of experience in cardiothoracics, yes, but the junior doctors who are transferring through or transitioning through, even if they don't want to do cardiothoracics, they have such a wealth of skills that they can then give to us. Lots of information about, like renal stuff, neurological stuff, and that's great, especially for trainees as well.
Someone right at the beginning of that process, actually having the juniors rotating through. I've got a lot of cardiology, cardiothoracic experience, but they have the rest of the knowledge that I'm still learning and still building on.
Personally, as a trainee, I find it really useful because you have that in-depth knowledge that I can, often we find as a junior doctor, you rotate round departments where everyone's rotating, so everyone's new, and not just you don't know the subject matter, which you might, but you don't know how a hospital works and the policies works, and that's what I can get from working with allied health professionals. What other things do you get from your junior doctors that come? Because we're really trying to focus on this MDT working and making it as collaborative as we can, rather than some friction that has happened in previous years.
Yeah, I think it's having that respect that you're working with doctors who have had years and years and years of experience to get to where they need to be, but that equal respect that you've obviously worked in for years and years to get to where you are. So it's utilising each other's skills, knowing your own limitations, knowing when to ask for help, but also really utilising them. So for example, we had a really good, thinking back a couple of years now, we had a fantastic junior doctor who was the most keen person to teach on imaging. So he wanted to be a radiologist, transitioned through cardiothoracic surgery, and his knowledge on reviewing CT scans, obviously x-rays, any kind of x-rays. So you had a patient who fell and they've got an arm x-ray. We don't routinely look at arm x-rays ever. So it's amazing for us to be able to lean on the junior doctors and say, look, you've got great experience in X, Y, and Z. You've done a rotation through neurology. I've got this patient. They've got these symptoms. Can you come while I assess this patient? And then it's like a collaborative approach. And it means that you can talk your plans, your system through with someone before you run immediately to that specialty. So obviously our escalation process would be to the registrar, but often the registrar again is specialised. So the next process would be you've got a patient who's presenting with strange neurological symptoms. You're going to pick up that phone, you're going to call the neurology registrar on call and say, look, I've got this patient. Instead of doing that immediately, you can talk it through with someone who probably has more experience in that area.
Exactly, and as junior doctors we may have rotated through and you see things with fresh eyes. Yeah, definitely. I think that's the best way for these roles to, intertwine into our service.
But equally, talking about allied health professionals, physiotherapists in those roles as well, like utilising physiotherapists who can do full body neurological examinations, and they do them far more frequently than we might. So utilising different people's skills in different settings to be able to give the patients wholesome, holistic care, basically.
Yeah. And so obviously, you've talked a lot about the variety of your role and lots of things you do. So what is your training, in terms of to get this? Say you are working as a nurse and you say, no, I want to be, to go further. What do you have to do? And who regulates you to make sure that you are meeting standards?
So the training, since I'm right at the beginning of it.
Expert.
Absolutely, well, I don't know about that yet. So the training, it's a full master's degree in advanced clinical practice. So in order to even get onto that course, you have to have several years of experience already. You have to show that you've got level 7 study or equivalent to just to get on the course, and often then it's funded with your role. So it's a 3-year master's, includes things like advanced health assessment, interpretation of investigations, non-medical prescribing, research, and then projects at the end as well. As nurses, we're regulated by the NMC.
Yeah.
But the idea of introducing advanced clinical practice was to create a standard, a framework that the term advanced practice could, everybody would be on the same page essentially, as opposed to historically when there's lots of advanced roles around, but no one quite knows exactly what level they're working to, so it creates that standardisation.
Yeah, so hopefully in the future, if you say that, then people are going to know because, it's a standard role.
Exactly, and exactly as you say, like making that distinction between I'm an advanced clinical practitioner or I'm an advanced nurse practitioner who maybe doesn't have the qualification to back it up. We've got so many amazing nurses who've done years and years and years experience who maybe have never had that training to reach the point that they're now being made to reach. Yeah. So there is no standardisation. In some centres, we're really fortunate that at the QE specifically, or UHB, they very much standardise advanced clinical practitioners. You go to a standardised university. Even the university courses now are being regulated by NHS England, which sounds crazy, but they weren't.
Yeah, strange to think they were. It's good they are now.
Exactly, they are now. So they have to meet, NHS England, who it is now, but Health Education England in the past. You have to meet their standards. You have to show that the course is covering the right material, and by the right material, it's basically hitting lots of standards for patient assessment. So a lot of your first year is looking very heavily on how do you assess that patient and what does that mean. So what are the differential diagnoses? How do you escalate that safely? What investigations would you use? Then you move on to like research stuff. You then go on to like your pharmacology, pharmacokinetics, so into your what they call the V300, which is your non-medical prescribing, which is quite funny because we often talk to our junior doctors about, or even our senior registrars about our non-medical prescribing. They're like, yeah, this is a lot more in depth than what we've ever had to do. And it is crazy because you do probably 9 months of work just for non-medical prescribing, which is incredibly safe. It's very full on.
So it sounds like your training is really, it's in depth, it's good, you've got a very good broad.
It's broad, yeah. And I think where it becomes more specific, especially in cardiothoracics, is having a good network at work. So making sure that you've got those senior people around you, making sure that you reach out to other people, and unfortunately, not all centres have that. So often you end up with very experienced practitioners who qualify, or they get tempted to do something else, they then move away, and you end up having to rebuild the service. But then if you've not got those senior people there, how do you benchmark yourself? How do you know that you're hitting the same standards as everyone else? And I think that's where societies like SCTS, EACS, and CTSNet actually really helps to be able to reach out to other people network with other people and just really make sure that you are doing what you can for your patients.
And that's what I was going to say, is that something like EACTS coming here is obviously so good for your networking, your learning, and just seeing other areas of the specialty. And I know it's your first time at a conference like this. How are you finding it?
It's been fantastic. Yeah, it's been amazing. I've met so many people. Catherine knows everybody. So it's really nice just to connect with other people in different roles, SCPs, surgeons, sort of see what other services are doing as well. We've had some play with different equipment that I day-to-day don't get to experience, but that helps to improve my care. Because now, if I'm dealing with a patient that might be going for that procedure, I have a better understanding of what's involved in that to kind of talk them through it. So yeah, I'm really enjoying it.
What have been some of your highlights, Catherine?
I think, I think actually we've just done a skills lab, learning a bit more about atrial clips and surgical ablation and stuff like that. So as Kat was saying, it's just such a great way to have a good understanding about what you're doing. So you can read so much about what all these procedures are and all the rest of it, but actually nothing can beat just getting your hands on it and doing it. Yeah. Because then when Kat's then clerking someone in and they're going for an AF ablation, she can then confidently be like, well, I know exactly what's going to happen because I did one last week on a model.
And I think what's nice for the allied health professionals is that on the Saturday, it's Allied Health Professional Day, so it's a day where there's lots of talks aimed at allied health professionals, and you can all come together and hear lots about it. Absolutely. So I'm sure that you're looking forward to those as well.
Definitely, and I love the fact that EACTS has gone that way as well, but SCTS, they have a whole Nursing and Allied Health Professional Forum that runs the whole of their 3 days of their conference. So I think for EACTS, then young enthusiastic people being really involved within EACTS is such a great way to build the rapport of nursing and allied health professionals, and more people coming. I think people are a bit scared about European conference, like, do I go, do I not go, will I know anyone? But actually everyone's super friendly.
Really friendly, yeah.
Really friendly. And you get to see so many people that you haven't seen for years maybe. I've worked in 3 different cardiothoracic centres. So it's so nice being able to come back, see some old mentors that I've had in the past, and I'm sure it's probably nice for them to see me as a young 21-year-old now doing what I'm doing now. And I think it's just a great way to keep in touch with people, to network, to benchmark, and to make sure that we squash that postcode lottery. Like, just because you live somewhere that's not London maybe doesn't mean that your patient should be treated any differently or be offered any different services. Improving our allied health professional forum and network is a fantastic way to be able to make sure that our patients are getting the best care that they can possibly be given. Well, it's an honour to be able to do that, really.
Yeah, absolutely.
Great. So I'd really recommend, if you're an allied health professional or anyone in training, coming to something like EACTS, meeting people, hearing about it. Thank you so much for your time, and I hope you enjoy the rest of the conference.
Thank you.
Thank you very much.